Hello, it is me, Dr. Renee, once again at Black Doctor. And tonight we have a really great discussion about prostate cancer. So I need you to go and get all the men that you know in your life and make sure they pay attention. Make sure I always ask, please like and start a watch party. Make certain that you share this with everyone that knows a male person, because this is so important, especially in the Black community. We'll talk about that as well, but it's really important. But tonight is really special. We have a patient and we have a physician to talk about prostate cancer. So usually, we just have a doctor, but today we have a patient as well. So please welcome my guests. We have Dr. Hollis Walker and Ronald Blackwell. Thank you, gentlemen.
Hello.
Hello, thank you for having me.
No problem, no problem. So I want to start at the very beginning. So Dr. Walker, please tell the audience exactly first, where is the prostate?
Yeah, so the prostate gland is essentially a pelvic gland that's sort of shaped like an acorn that is only in male persons have a prostate. It's sort of deep to the urethra, and it's just a deep pelvic organ, I guess, if that sort of clarifies things. It's hard to describe. I'm thinking sort of three-dimensionally, but yeah, I think that would, I can't think of a easy way to describe it anatomically. It's typically felt on physical exam through a digital rectal exam. So your primary care physician or your urologist might do a digital rectal exam to feel for the prostate gland. So that's how you can, that's how that provider could feel the gland from the external world. But you can't physically see your prostate gland. It's deep in the pelvic cavity. Does that make sense?
Definitely.
Okay.
And then also, can you share with us who should go and have the digital rectal exam or even the PSA? And we'll talk about what PSA is as well. But who should get their prostate checked?
Absolutely. So PSA stands for prostate specific antigen. That is a blood test, and that blood test will tell most often your primary care doctor, again, a medical oncologist if you've already had a prostate cancer diagnosis established, or urologist. It will tell those individuals involved with your care essentially if there are prostate cancer cells floating around in the bloodstream. So typical screening for prostate cancer is not really a black and white answer these days. The United States Preventative Task Force has recently made some updates to guideline recommendations for family medicine physicians and internal medicine doctors and typical primary care physicians regarding screening. That used to include most male patients over age 50. Is sort of a general rule of thumb. In the African American community, prostate cancer is certainly far more prevalent, so we have a higher risk of prostate cancer development. And so, in general, rule of thumb would be most male persons over the age of 50, if you're, in a high risk category, which would mean African American men. If you have a first degree relative affected by prostate cancer, then you're going to start screening sooner than 50. You should be getting screened roughly around the age of 40 if you're African American male. And for instance, if your brother or your father has prostate cancer, you would want to start screening at 40.
Okay. So Ronald, can you please share with us your story? Because I know Ronald is actually a young guy. So, so he...
And not that young.
No, but I'm saying technically, from what Dr. Walker just said, you wouldn't have even been screened yet. So please share your story.
Exactly. It's like Dr. Walker said, my story, it started, I would say I was about 44 years old. I was 44 at the time. And I started experiencing frequent urination at the time. And I thought didn't think it was much, because at the time I was doing it wasn't a water challenge, but I was basically challenging myself. I was sitting at my desk and I would try to drink 64 ounces of water at doing an 8-hour period at work. So, I thought nothing of it. I'm drinking water. Of course, I'm like, because I'm intaking so much fluids, water, I'm going to be using the bathroom even more. So I thought nothing of it. And it was like one night I was driving home and I had the urge to urinate so bad that I literally had to like take a chance of pulling over because I just couldn't hold it. And so I got home and I told my wife, I said, hey, I had to use the bathroom. I couldn't hold it. And she's like, oh, really? I was like, yeah. So I brushed it off, and maybe like a week later, the same thing happened again. And now this time I'm feeling like a burning sensation. So again, I talked to my wife and she mentioned, hey, you could have like a UTI. So I said, you know what? You're right. I could have like a UTI. So I called my primary care physician. I didn't actually go to them. They have like a sub office where you can actually just walk in, almost like an urgent care almost. So I walked in and I told them my symptoms, what was going on. So they took urine, they did tests, and they said, we can do we don't see anything. We're going to do a culture. We'll call you back in 2 weeks if we see something. Never got the call back. So they said it was nothing. And so again, now I'm experiencing even more and more now. And I'm like, something just isn't right. So I called my primary care physician, and I usually get, a physical during my birthday, which is in December. And now it's 2019, it's summertime. And I called and I said, hey, I think I need to, I want to come in early. And he said, sure, I have something in late July, early August, whichever one you want. I was like, whichever one you can give me, I want to come in. So I went in and, I always had like a clean bill of health. I was always worried about like my glucose levels. I would always get that blood work done like twice a year because my grandfather was a diabetic. So I wanted to stay on top of that. So I did we did the routine physical, did the blood work that they can do in the office, the lab there they have in the office. And, my physician, he said, everything looked fine. Is there anything else that, you want to talk about? And I said, hey, I need to get a PSA test done. And he just had this look of confusion. And he's like, why do you want to get a PSA test done? And I said, hey, I found out back in 2016, my dad got diagnosed with prostate cancer. And now I'm experiencing frequent urination and like a burning sensation. And he looked, he said, okay, say no more, let's do it. So we did it. And my PSA came back high. And he said, hey, I'm going to recommend you to see a specialist. You need to see a urologist. And that's where the story started. The journey started, I would say.
Yeah.
Yeah. And if you need me to continue.
Yeah, go ahead.
Okay. Okay. So I met with the urologist. They went over my health record and they said, hey, you got a clean bill of health. You really don't have any issues, but based on the symptoms that you're telling us, and we're looking at your PSA, it's high. Your PSA is definitely high. So, it sounds like you could have a prostate infection. I was like, oh yeah, I did kind of like Google that and I've seen, I could have like BPH or a prostate infection.
Sure.
So they did a DRE and they definitely said, hey, it's definitely enlarged.
Mm-hmm.
But we think it's enlarged based on, because of your age, your health, everything is just, we think it's a prostate infection. So they explained to me that with the prostate infection, you have to be on antibiotics like 30 to 40 days it was. It's like because it takes some time for the bacteria, the antibiotics to work and get to the bacteria and clear it out. So I said, perfect. I said, fine, no problem. I can do this. I can do 30 days of being on, I want to say it was doxycycline.
Mm-hmm.
I can do that. So they put me on the antibiotics and they told me after you finish the antibiotics, we're going to wait a week and then you're going to go take a PSA test. Mm-hmm. So I said, okay, perfect. So I did that and my PSA, it came down some, but it still was alarmingly high. And my urologist at the time, he said, it came down, but I think it's still too high. Not I think, he said, it's still too high for me. So he said, okay, this is what I'm going to do. I'm going to give you additional antibiotics. He gave me a stronger antibiotic, a Zithromax or something like that it was. So I was on that for a little bit and he's like, okay, let's go back and get another PSA test. So the PSA came back. It slightly went down again. And he said, just didn't come down enough for me now. So now we need to take next action. And he said to me, he was really trying to avoid the invasive biopsy. He just did not want to do that. So he said, let's do an MRI. So I said, okay, fine, no problem. Let's do an MRI. So I went.
Wait, sorry, Rod. Can I
Uh-huh.
just clarify a
Mhm.
couple things before you get to the imaging? So, thank you for sharing your story. This is really important. I guess I want to clarify that that abbreviation DRE. That
I
stands
was
for the
just going to do that
yeah,
too.
yeah. That's the digital rectal exam that we talked about, the physical exam finding. So that's important. And really, what's I think critical for these stories is what was that baseline PSA, Ron? Do you remember how much what that number was? Unit of measure is
Oh,
usually in nanograms per milliliter. So was it like
that's a good question because I do remember seeing two different. Uh,
numbers?
uh, yeah, I
Okay.
do remember seeing that, and
Okay.
it was kind of confusing at the beginning, but I do know it was 30. It was extremely
Oh,
high.
okay.
Yeah,
So at the beginning, it was at a 30.
yeah, yeah.
Got
It
it.
was
Okay.
extreme. Yeah.
Yeah, a
So,
30 is very high, and I think that's also probably relevant for this storyline to kind of talk about a normative range for PSA value. So normative values would be 0 to less than, so anything from 0.00 to less than 5 nanograms per milliliter. Okay. So
yeah.
and something that high, I would say that high in the quotation marks greater than 20 is usually something concerning that we would recommend somebody for biopsy. Okay.
And the other
So
thing, BPH, can you
oh,
also
yes,
explain what
yeah.
that is? Yep.
So BPH stands for benign prostatic hypertrophy.
Yep.
That's typically an age-related process. So as we discussed, all male persons are going to be born with a prostate gland, and as you get older, your prostate gland will enlarge as a natural part of aging, and that's just sort of something that. And there's some people who theorize if most men live long enough that they might develop a prostate cancer, just the nature of the growth of the organ. So as a man gets older into the seventh and eighth decade of life, that prostate gland can get enlarged. You can have urinary frequency symptoms, urinating at night, known as nocturia, urinary hesitancy, or weak stream or flow of urine. And there are lots of medications that are designed to help patients who have that benign prostatic hypertrophy. Not very common to happen in younger men, though, you know?
Yeah.
So,
And the other thing I also wanted to mention, digital rectal exam means digital rectal. So that means they're sticking a finger in your rectum to feel for your prostate. So, because there's somebody that's like, what does that mean? So,
absolutely. And
Yeah.
that is a very important part of the clinical exam. They can usually feel, most importantly, for the smoothness of the gland. Again, as I said, it's kind of a difficult concept to describe anatomically where it is, but if you're going into your doctor's office, how are they going to check for that in a similar way that they put the stethoscope over your heart to listen for your heart? This is going to be felt with, a physician, provider, with glove. They'll be wearing a glove with surgical lubrication and going into the putting their finger through the anal canal to feel through that area to sort of feel for this acorn type structure that should feel rather smooth. If it feels nodular, that's clinically concerning. So they'll put the finger there and try to feel for the smoothness of the gland and to see if it feels enlarged.
awesome. Okay, go ahead, Ronald.
All right. So I left off on getting the imaging done, the
Yeah.
MR, the MRI. So we got that. I got that done. It came back. It was abnormal. He said, my urologist, he saw things that was just abnormal, and he said it wasn't small neither. What he saw was fairly large, and now it was time to immediately do a biopsy. So I said, hey, let's do it right now. And he explained, he said, no, I can't just do it like that. I have to give you a antibiotic pre, during, and post. I said, got it. And he explained to me about, preventing, infections because the biopsy is so invasive. So eventually I took the antibiotics. We did the biopsy. He did 12 pricks. And out of the 12, I want to say it was like 7 to 8 that were benign. One was actually, suspect, and the other 3 were benign. I'm sorry, the first, the 7.5 to 8 they had cancer cells.
Mm-hmm.
So let me correct that. And then the 4 actually were benign. So he started explaining to me. He went over the grade and the next steps far as treatment. And he explained to me, like you guys are saying, my age, my health, I'm a good candidate for surgery, because he was leaning for surgery. He mentioned radiation, and, he talked to me about, hey, do you plan on having any more kids at the time? And I said, and my wife was in the office with me at the time. And I said, well, you can look at her now. She's pregnant. So we're pretty much done. So he said, okay, so, surgery is definitely the way to go. I recommend surgery, but, I can't pull your hand and force you or make you do anything, but here's the option. And this is what I recommend for you. So we went through that, and I said I wanted to do surgery, and we ran into some difficult times. This is during when COVID-19 apex is getting ready to hit. Mm-hmm. Yep. And I'm in the state of Maryland, and basically my urologist, he got back to me and he said, before this, I'm sorry, I had to go do the bone scans, the imaging, the CT scans and everything to make sure nothing didn't spread. And he got back to me. He looked at all my imaging and he said, your imaging looks good. So that means we can definitely proceed with surgery. And I said, perfect. Thank you. So now, as I was mentioning, COVID-19 hits. It's like the apex, and there's no real protocol. This is like an April, so there's no real protocol, or like how they're moving patients around, what nurses dealing with patients, outpatients, and stuff like that. And at the time, my urologist at the time, he was really concerned about me possibly being exposed post-surgery. Mm-hmm. And where at the time where he did the surgery at the hospital, he knew for a fact that there were COVID-19 patients. So, and then at the time, the state shut down non-emergency surgeries. Sure. So I'm looking like, what do you mean non-emergency? This is an emergency for me.
Sure. That's you, yeah,
for
definitely.
Me, this is like an emergency. I can't wait. I don't want to wait this out, because right now my anxiety is going crazy, and I understand the protocol and the logistics of emergency surgery. Like if somebody having like a severe heart attack, I get that. So I understand that now. I understand that cancer has like that gray area where you have to wait, and it's the time process and everything. So being anxious, I wasn't going to wait. So I Googled again. I got on the road and I drove north. I won't say the name of the place, but I drove north and I went there. I met with some, the people there were fabulous. I met with the urologist there, and I would just say this, his bedside manners, I just was not comfortable with it. And it's just, I was like, there's no way I can let this guy do surgery on me. So I came back, I told my wife, and I said, actually, no, while I was there, I'm sorry. While I was there, I called my urologist back home, and I said, I'm really not comfortable with, the urologist that I'm speaking with right now. And he said, okay, well, because we're in this whole pandemic, did you get a date? Did you get a date for surgery? And I said, yes, I got a date for surgery. He said, okay, let's do this. Just keep the date. You keep that date. I said, I understand what you're saying, but I'm not really comfortable with this guy. And he said, but, you still keep that date. We can work out something. I said, okay. So I kept the date. I did everything. And it was time for me to go back there and do the pre-op. Mm-hmm. So I was getting ready to get in my car and drive up there, and something just told me, don't go, because you're not comfortable with this urologist. So I didn't go. So I called my urologist here, and he said, well, what I can do is I can give you some medication. I can give you a shot, and it basically is going to slow your testosterone down. It's basically like a chemical castration. And I was like, huh? He's like, yeah. He's like, because this particular cancer, with the prostate cancer, the cancer cells need testosterone to actually grow and spread. So what it can do is it can stop them. It can just, it can stop fueling them, and they can stop growing and basically halt them, leave them idle. And he said, in some cases, they can actually die too as well. So I said, okay, I thought about that. And during that time, I told my mother-in-law what was going on, and she said, I just remembered, my neighbor 20 years ago, he used to be a research oncologist at Johns Hopkins. So she ended up calling him and just having a general conversation with him. And he says, he asked about me. And he said, so how are they doing? And she said, yeah, Ron, he just got diagnosed with prostate cancer. And he said, well, he's at Johns Hopkins right now, right? And she said, no, because he tried to get into Hopkins, but they said because of COVID-19, they're not accepting anyone right now because, again, they had no real protocol. And mind you, I forgot, I left out that my primary care physician practiced out of Johns Hopkins. It is Johns Hopkins. So he said, he hung up the phone with her and said, well, before he hung up, he said, I'll call you back in about 5 minutes. So he called her back and he said, tell Ron he'll be expecting the call in the next 15 minutes. And John Hopkins called me in 15 minutes. So not only did I get into Hopkins, but I got like the head urologist in John Hopkins.
That's excellent.
That's
That's very
awesome.
good. I'm very proud to
Yeah.
hear that. Very excited.
Yeah.
Yeah.
I attended college at Johns Hopkins. I was very lucky to study
Yeah.
there. So I'm always very proud of that institution and how they take care of the people in the community. So I'm excellent. I'm sorry you had to go through that experience when you
Yeah.
drove north, but
Yeah.
it's nice to see that there is somebody who wanted to make a difference. I'm sure Dr. Renee, I'm sure one of the guiding principles you probably talk to all patients about with every sort of healthcare interaction experience, it's so important to be taken care of by people that you feel comfortable with, you know,
Yes.
Ron. And what you just described is really, that's probably 9/10 of the battle with most, patient care interactions and issues that people have, is that you need to feel comfortable and confident with the person who's taking your well-being, your health into their hands. So,
Yeah.
so good for trusting your instincts on that. What are some other things I was going to
Yeah.
maybe elaborate on further?
And I
I'm
was going
sorry.
to say also, I always advocate that you have to advocate for yourself.
That's very important.
So
Yeah.
and what people don't realize is that doctors work for you. So
Mhm.
if you don't feel comfortable, then you need to fire them and move and find another one. And
Absolutely.
so
Yeah.
if you
Yeah.
didn't feel comfortable and something just didn't tell you it was right, then don't go with it. And that was
Yeah.
great that you stuck to your guns because look, a door was opened anyway.
Absolutely.
Yeah. And I'll say this. So when I went down to John Hopkins, I took all my, my documentations. I had my biopsy report with me, and I presented it to the doctor there, and he looked at the biopsy, pulled out his pen, started drawing on it, and looking at me. He pointed. He's like, "You see this here?" And he's showing like the benign areas. He's like, yeah, this area here. That means we're definitely going to do the surgery because that's what you want to do. I'm looking at your scores. Surgery is definitely the way to go. I was like, doctor already said I want to do surgery, so I'm fine with that.
Sure.
And he draws a line. He says, and this area here, I'm definitely going to be able to do the nerve sparing technique. And I bring this up because, when I went north, the doctor, he just basically said, 100% erectile dysfunction. He just looked at the biopsy, said 100% erectile dysfunction. But this doctor here at Johns Hopkins, he, like I said, he was doing markup on it. And he said, yeah, I'm going to do the nerve span. I'm going to do the nerve span. You're a good candidate for that. And, looking at everything, it should go well. Look, you don't have any pre-existing health conditions. So I'm really not concerned. And we can proceed with the surgery. And he did also mention prior to surgery, he said it's a good chance, that I am going to send you to the oncologist after this. And because of the family friend, not only did I get the best surgeon, I got like one of the best medical oncologists at Johns Hopkins, and one of the best radiologists. It was like a whole team. They all were working on me for my healthcare, and I was just blessed to have those terrific doctors.
That is an excellent story,
That's awesome.
Ron.
Yeah.
I would say as a medical oncologist, there should usually be a multidisciplinary approach to a cancer diagnosis.
Right.
Most problems with cancer diagnoses involve one, if not all three of our treatment modalities, which would be surgery, which a urologist could perform, radiation, which a radiation oncologist can perform, and then some form of systemic therapy, which a medical oncologist could provide. That could be a form of what you alluded to earlier, talking about a hormone shot. that would block testosterone. We call that androgen deprivation therapy. So prostate cancer is fed by testosterone, and so blocking that hormone is trying to prevent, further spread and growth of the prostate cancer. Also, medical oncologists, of course, most people understand, provide systemic chemotherapy or sometimes immunotherapy to cancers if the cancer has spread beyond the primary site of origin. And unfortunately, many prostate cancer diagnoses are made with the individual being diagnosed at stage 4, where the disease has already spread to possibly the bone, the liver, or the lungs. So I think a lot of this talk is to try to prevent those sort of complications from happening. And so you talked about your PSA score, being very high, didn't come down with antibiotics. Going for biopsy seems like a very practical thing to do, again, with a PSA greater than 20. And then, so when that biopsy occurred, just going to try to fill in some of those details. You mentioned about the 12 cores that were obtained. Okay, so if you think of it, like I said, as an acorn or maybe like a bean or seed laying on its side, they're gonna probably, if you slice that in half and then you take the left half is having 6 cores and the right half having the other 6 cores. And if you had more than 50% of that gland involved with prostate cancer, they will take different samples of all of those areas. In your case, you said 7 or 8 out of those 12 core samples had prostate cancer. And I think you mentioned that they scored those as well, right? Do you remember the phrase Gleason score?
Yeah. Yep. Some of them were like a 3-4, 3-3, 4-3. It was like those numbers.
Okay.
Yeah.
And anything that was a 4-4 or 4-5 or anything like that?
But I did have one area that was a 4-4. I do remember having one area that was a 4-4.
Yeah. So what does that mean? Is that when a cancer diagnosis is made, they take that cancerous tissue sample and they look at they look at that pathology sample and they grade it next to a normal prostate gland. And the closer and more similar to normal prostate gland, the lower the number, so a score of a 2 or 3 might look a lot like a normal prostate gland. The higher the number, the more advanced that cancer is in that particular area, and the score gets higher, So they typically, about a 4 or a 5 is about as advanced as the number would get. And then you get a composite score. So in one place you had let's just say you said a 4, never a 5, right?
Yep.
Uh-oh. Did he freeze?
Yeah, he paused. Yep.
Uh-oh, what happened? Oh, there he is. He's back. Okay, you're fine.
Yeah. So you had a couple.
Uh-oh, not again. Uh-oh, Dr. Walker.
Oh, he's frozen.
Oh, there he is. He's back. Okay.
So so in those areas, I think you said you had a 4 + 5 or something, right?
Yeah, I had the majority were like 3-4, 4-3. I did have a 4-4. He froze again.
Oh yeah, he did.
He froze again.
Sorry. Okay, I'm here. I don't know. I haven't touched my phone. I haven't done anything. So.
Oh goodness, he was doing fine. Now all of a sudden, I don't know. It's frozen again.
Yeah.
Well, I was going to ask you. So, what stage did they say your prostate cancer was?
After the surgery and everything, they said I was a stage 3.
Okay.
They said I was a stage.
Okay.
They said I was.
Okay, he's back. Okay, I think.
Oh, no.
Maybe not quite.
Dr. Renee, is it my connection or?
We're not having a problem. Yeah.
Okay.
We're both good.
It's went out again.
Yeah. Yep.
Goodness gracious.
Yep.
Okay.
All right. There he is.
Maybe I can try to go. Yeah. Maybe I should try to go off my Wi-Fi. Hold on.
Yes, that's a good idea.
Okay.
Yep. He's still up.
Okay.
Okay.
There's hopefully that's
perfect.
Better.
Yep.
Okay.
Yeah.
All right. Good. Sorry about that. Ron, you with me?
That's okay.
Dr. Renee?
Yep.
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 Uh-oh, can you not hear us?
Yeah,
can you not hear us?
You're moving, but we can't hear you. Can you hear?
No.
Oh,
we could hear.
Yep.
Okay, you hear us? Okay. You're good? Okay.
I think so. Good. Okay. So, what
So the
was I
4 out
saying
of
here?
4? He had a
Yes.
4 out of
Yeah.
4? Yeah.
4 out of 4. And, those, that would give you a Gleason of 8. Okay. And so that's what we would, you know, how would we classify your prostate cancer? You would be considered with the intermediate risk type of prostate cancer with that sort of, PSA over 10, Gleason score of about 8, and so I think it's, it was, I think, a good recommendation for you to see the medical oncologist, and another thing with these diagnoses, you meet the first provider you talk to can sometimes be a surgeon, maybe it's your primary doctor. You can get an opinion from every part of every part of that puzzle I talked about. You can get a medical oncologist opinion. You can get a radiation oncologist opinion. Primary, your initial treatment for prostate cancer could be with surgery or it could be with radiation. And so, you always have options as a patient,
Yeah.
and you can always explore those options. So,
Yeah. And basically what you just said about the scoring and the Gleason, that's exactly what was like on my biopsy report with the
okay,
Gleason score,
okay,
the risk and everything. It was, you were pretty spot on with it. Yep. And like you said,
good, very good. Okay,
the different, because like before I started seeing the radiologist, I signed the agreement to have radiation treatment. And I noticed on the on like a disclaimer, it mentioned, I can't say it verbatim, but it was something to the reference to like controlling or making sure your PSA comes down or something like that, to that nature. And I remember saying to the doctor, I said, hey, you do know my PSA is 0 detection right now. It's been that for like the last 3 times. And he said, yeah, you're here because we're going to make sure we keep it that way. That's why you're here with me.
yeah,
Said, and, again, he explained, just sterilizing the prostate bed area and like that, the pelvic area, everything around the prostate. And I said, oh, okay, makes sense, because when my surgeon and the pathology report came back, he did mention, he said the microcell, they seen microcells, like in the margin, they did see microcells. So that was why he recommended me to go to the medical oncologist.
okay, got it. Yeah. All right. So yeah, that means that there were some maybe micrometastatic cancer cells that were maybe at that surgical bed, and so getting some radiation after surgery is to try to completely treat that area to get it, cancer free. So good, very good. Okay. And then, have you been continuing with those hormone testosterone blocking shots?
Yeah, I'm on like a 3-month intermittent, 3-month schedule. So I'm headed towards my 3rd one in the middle of December. So I've done 2 so far.
Okay, got it. And how long are they planning to treat you with those?
They said 6 months to a year. I actually have an appointment with my, a televisit with my medical oncologist Monday. So he said 6 months to a year. So
that seems appropriate.
I said, okay. Yeah. I said, I'm going to be a good patient. Whatever you recommend, even though the shot is the testosterone shot. It's bothering me, but
Yeah. So that's getting healthy, right, and staying healthy, and you have an undetectable PSA, and they want to keep it that way. So that's very important. And that shot is a testosterone blocking shot. That's just to prevent your body from producing more testosterone that could fuel a prostate cancer. And again, the goal is to get you to less than 0.01. Side effects from those hormone blockade shots, they're typically given every 3 months, as you described. There's an every 6-month dose, but the higher the dose, the more the side effects. Those can come with hot flashes, erectile dysfunction. Those are typically what most men feel with that. So that's a phenomenon that can be different and unusual for people to think about as a man having hot flashes, because we think that that's something that's uniquely specific to just postmenopausal women. But no, yeah. So yeah, that's why that and the erectile dysfunction components are the biggest quality of life features associated with that form of treatment. So, but it's you have a finite plan for that, which is good. So it's going to not be forever, which is great. So excellent.
Yeah, and that's exactly what was explained to me, because when I started to complain about it, they said, hey, just remember, this is something that we're doing to you. This isn't you. So just understand, this isn't you. Try to use the logical side of your brain, not the emotional side, to understand this is not you. This is just something that's temporarily. And, you just deal with it for now. And it's to help you be healthier. And, keep your PSA at 0 detection.
Mm-hmm. Very good.
So, Dr. Walker, can you talk about how how curable prostate cancer is once it's found early?
Yeah, that's a good question. Yeah, I mean, usually these kinds of situations are very, again, as you said, effectively right now, you've got no evidence of, sorry, I'll just rewind a little bit. When you had those scans, right, they were doing the bone scan and the CT scan, that was at the initial part of your diagnosis. That's sort of the staging workup to make sure you didn't have metastatic disease or stage 4 disease or cancer that had spread to your body. So you had no signs of any of those things, which is good. So you had an early stage prostate cancer, probably stage 2 or so, when it comes to prostate cancer or any cancer diagnosis, there's usually a stage 0. The only one that has stage 0 is a particular type of breast cancer, non-invasive breast cancer called DCIS. Most other cancers are stage 1 through stage 4. Anything that's not stage 4 is treated with curative intent, which is really, to your advantage. So, it's one of those things that doing the treatment modalities that you're doing should afford you a really good long-term prognosis. Each individual is different, so you never know what the future holds or what guarantees there are for a cancer diagnosis. But you, Ron, as you discussed, you've decided to be adherent to your doctor's recommendations. You're going to continue to follow up as recommended. And so, I think that they'll be on the lookout, to keep your PSA at an undetectable level, 0.00 nanograms per milliliter. So, but yeah, you should have a very high chance for a good outcome, with your disease being staged as it is, from what I'm hearing. The intermediate risk, with it being that Gleason score 9, it makes it a little bit more aggressive than these lower stage prostate cancer diagnoses that some men get, and those are sometimes found incidentally. Some people might have a Gleason score 3+3, which is 6. That's a very common thing that happens in older men, or any man at the time of diagnosis. A lot of those cancers are not being treated; they're just being recommended to do what's called active surveillance, or following the cancer, in terms of following the numbers to see if things change, So it depends on the Gleason score in terms of if it's in the low risk, intermediate, or high risk category, and the stage of the disease.
Definitely. And we have to mention I think it was 2 weeks ago, Friday, Al Roker actually announced that he had prostate cancer. It was caught early, but it was an aggressive type. So actually this week he did come back to the Today Show and came on air and talked about he had his surgery. He's at home recovering still, but he had his surgery and he's feeling great. And his doctor was on and they said that they got everything and, he should be coming back to work soon. But this is why it's so important, because Ronald honestly sounds like the perfect patient. Like, I need a husband like that. Because like my father, oh my God, we struggle with him as a patient. And, men as patients, period. But Ronald seemed to be very on top of it. I like the fact that you understand exactly what's going on. You ask questions clearly because you have a clear understanding. You're, following the protocol. Just because you don't like it is not that you're not going to do it. You're going to do it because you see that this is what needs to be done and it's a temporary thing. And so I think that's very important. And we need more men, especially in our community, to be so aggressive with their health.
And that's, no, I'm sorry, doctor.
Oh, I was just going to say, Ron, I also applaud you for that. As a physician, is your background in healthcare?
No, it isn't. It isn't. It isn't.
So I was very impressed.
You're a well-informed patient. you're just, I think that speaks volumes. You're a well-informed patient. You remember your journey, your story, because you lived through it. But being able to, to tell it and know those details, I think that also speaks to your treating team, that you've been well informed enough that you can, you sound like an expert in the field based on,
Right.
you know what you've lived through, but you understand the terminology, you understand why things were happening to you and the reasons to do, X, Y, or Z. So that's a really important part with going through a cancer diagnosis problem. So.
And kudos again to your team, because that shows that they did take the time to explain things so that you understood exactly why things were happening. So, and that's important, because if people don't know, then I think people aren't as compliant as they should be when they don't understand why. Why am I taking this? Why am I doing this? But when you understand, I think you have much better, compliance, and patients are good patients.
Absolutely, yeah, good.
Yeah, and that's one of the reasons why I started my group, my
That's
Facebook
what I was about
group.
to say. Yes.
Yeah, my group called PATH. So you can come on Facebook, look us up. It's called PATH, and it's basically prostate awareness for total health. And I'm just becoming an advocate, and I just want to bring awareness to something like this, because in the Black community, we don't talk about something. We already don't go to the doctors enough, but we don't talk about some things of this that can lead to erectile dysfunction. We don't talk to stuff like that. We don't talk about.
Wait, let me interrupt
DDR.
you. Did you hear that he mentioned that his father had prostate cancer, but he didn't find out till 2 years after the fact?
Exactly.
And that's a problem in our community when we don't talk about because you have to have your health history. All this information is so important. Dr. Walker, as an oncologist, I know colonoscopies. If you've had colon cancer in a first-degree relative, that's another one that you need to know, that because you need to have your colonoscopies earlier, probably, than everybody else.
Absolutely. Yeah, that's 100. Yeah, this is Prostate Cancer Awareness Month. We call it Movember. People are growing these big mustaches. And so we're on time to be talking about this subject, but also I'm very passionate about trying to help and treat patients with colon cancer as well. And we all know, unfortunately, what happened to Chad Boseman.
Yes.
Colon cancer had previously been recommended for screening colonoscopies in most adult patients at age 50. Now that recommendation, especially in the African American community, has been changed to 45. So, when I turn 45, I certainly plan to get my first colonoscopy. If you have a first-degree relative, and that individual, if your mother or father or brother or sister or first-degree relative had a colon cancer diagnosis at 51, then you should be getting your screening colonoscopy at 41, 10 years younger than that first degree relative. So, and absolutely. And that sort of communication within the household, within the generations. And, I think we have to do better as a community in terms of talking about what our medical problems are and what sort of diagnoses we're carrying, so it can affect someone else,
Exactly. And that's why I'm saying, and I think his group is so important, because men need to talk about these things. And if they talk about it with their friends, then maybe that can encourage someone to go home and talk, because your wife needs to know if you drop down of a heart attack or something, she needs to be able to say, oh, he was treated for this, before we got married. I didn't, otherwise he could have been treated for prostate cancer, but you didn't know because you guys got married 3-4 years later or something. You know what I mean? Just little things that you need to make sure that the people around you know what's going on.
Absolutely. Definitely.
Agree 100%. 100%.
So definitely, please check out his Facebook group. And I will definitely make sure I get a link to put it in the post as well. But make sure you check out his Facebook group.
Yep.
Is there anything else you wanted to share, Ronald?
Just, for our community, really pay attention to your health. Listen to your body, because your body is going to talk to you. Don't brush it off and think it's just, I slipped and fell. It's nothing. No, really pay attention to it, because your body sends you signals, and your body can let you know what's going on. And you need to go seek medical professionals such as Dr. Renee and Dr. Walker, because he's pretty much been spot on with some of the things that I was diagnosed with. Yeah, he's been when you mentioned the 10-year difference. My urologist at Johns Hopkins, he immediately asked me, do you have any sons? I said, yeah. He said, make sure when they get around 30 years old, make sure you tell them to get PSA test.
Mm-hmm.
I said,
Mm-hmm.
of course, I
Absolutely.
definitely plan on doing it. You know, that is like my mission right now, and it's just to bring awareness to a cancer like this. This, you know, what is the second most treatable cancer in America, and you know, we can treat this if you be proactive. You just be a good patient, but like you said, you also have to put it back on the doctors, and you know, you have to demand. You know, be passive aggressive. Hey, doctor, I want to get a PSA. You know, I know I don't fit the criteria at the moment, but I want to get it. You know, I want to get this. Like I plan on getting once I finish my radiation treatment, I have about eight more sessions. And I don't think I mentioned the sessions. It's 5 days a week, as Dr. Walker would know. It's 5 days a week, and it's basically like getting an X-ray. And you sit down, you lay on the table for about 10 minutes, and you know they mark you. It's targeted areas. And, you know, it's not like your whole entire body is being beamed with radiation, because a lot of people hit radiation and stuff like that. And they get nervous and they get scared and run. I'm like, no, it's 2020. Technology is a whole lot better. A whole lot better. And it's just targeted. The worst part about the radiation treatment is holding water in my bladder. That's the absolute worst part. Because you have to hold it. You have to have a full bladder.
And you know what else? I also wanted to mention that if there's a whole lot of people who do not go to the doctor because they don't want to know. That's the wrong thought process. Because you know something is wrong. Okay, but you should go, because when it's early, they can do something about it, and you could live long and prosper. But if you wait and wait and wait, and then you die at such a young age when it was something that so easily could have been treated early on. So please don't ignore your body. Like you said, listen to your body and tell the doctor, you know, this is what's going on, and I don't know what this means, and let's figure it out.
Yeah, Dr. Renee, I think you speak to a really relevant component in terms of, you know, maybe these are urgent legends or different myths or different sort of belief systems, which, you know, we all, culturally speaking, come from different belief systems and values. And I think all of those things should be valued and appreciated. But I think, Ron, you're speaking to a valid point, right? A, listen to your body and know your body. B, denial does not change anything, you know? And so this phrase, sometimes you hear people say, oh, I'm not going to claim that, you know, that comes like not claiming something isn't necessarily going to change that outcome, you know? And so if it's really there and it's in black and white on a piece of paper, that's the diagnosis. It's really there. You know, that's just, you can't argue with that science. You know, I did want to just have speak to the point of, you know, a cancer diagnosis does not obviously just affect one individual. A cancer diagnosis affects families and generations. And obviously, the more empowered and more informative you are, Ron, the better you can be a better father and a better protector for your children and for, you know, anyone else out there. So, that's a very important thing. Another thing I just wanted to speak to really briefly is again, you know, I reference this idea of with a cancer diagnosis, there are 3 types of people that can help you: surgeons, radiation oncologists, medical oncologists. With any cancer diagnosis, definitely reasonable to say, can I hear and talk to a person who, you know, a medical oncologist, a radiation oncologist, a surgical oncologist, or a particular specific surgeon, just so that you get all the opinions that in terms of how you can get your treatment and management for your condition, you know, and then you can hear about these different treatment modalities. Yes, radiation is very brief, you know, as you talked about, you come in 5 days a week for about 10, 20-minute sessions, you know, and nothing hurts. You know, none of these treatment modalities should hurt you. All of those things like radiation, targeted beam therapy, it's not going throughout your whole body. It's really just hitting the particular prostate bed and that gland and the, you know, the tissue around it. You know, surgeries happen just in one area. And my field as a medical oncologist, we do use systemic therapies. But again, that's when a problem has already spread to other parts of the body and other organs. So things like chemotherapy, I want to continue to use the phrase immunotherapy, and sometimes endocrine or hormone therapy, similar to this, androgen deprivation therapy you're using. These are all treatment modalities that, someone in medical oncology would use to treat a cancer that has, might have spread to other parts of the body. But none of these things should be entities that hurt you, and they should always be described and discussed with enough detail that you feel comfortable receiving any part of it. Okay, so that's really it's to the person prescribing it to be able to talk about those things and side effects from that. So,
Exactly.
but there's good help out there for people who are looking to get it. So,
thank you so much. Go ahead.
No, I was just going to say, my thing too is, you have like pros and cons or risk and reward, and most professional doctors, they're not going to, prescribe something for you where the risk outweighs the reward. So you have to really pay attention to that. And for example, like my situation when my surgical doctor, he told me, he said, hey, there's going to be a chance that I'm going to send you to the medical oncologist, and then you're going to go to the radiation doctor. And I said, hey, I'm going to follow these steps, and because their whole goal is, as you mentioned, Dr. Walker, in the beginning, it was for cure. It wasn't just a treatment. Just say, hey, we're going to try to just slow it down. It was, he was like, our main goal is like, hey, you've been here for 45 years. We want to make sure you're here another 45 or 50 years.
Absolutely.
So,
Absolutely.
we're
Exactly.
The whole goal is to cure it. And, before I left the medical oncologist, and I said, he said, your blood work has been looking great. Like I said, it was a zero detection. Your PSA was zero detection, and you're going to go to the radiologist. And I said, hey, so, what does it look as far as like me being cured? And he's like, yeah, you like 90%. I was like, I get you. I know you guys can never say 100%. I get it.
Yeah,
I get it. And so he said, we just, you do this, you stay with the radiologist, and we're going to continue to monitor, and you go from there. That's where I am.
That's the way to be.
I just really want people to know, like, you can be treated. Do not have that mentality. If I don't want to know. You do want to know, because there's treatment out here that can help you, that will save your life, and not just your life, but like you said, Dr. Walker, the next generation. They can save people's lives. So you want to seek it and be aggressive with it. Don't sit back and do nothing. Be aggressive.
Yeah. And now I'm personally biased as a medical oncologist. We tend to be some of the most optimistic people in the world. We want to all treat, beat, and cure cancer. So we're all very upbeat individuals. I mean, my personality, I tend to be very much on the sunny side of the street about things. But with we know these are complex, difficult, problem-solving cases, and at the crux of it is an individual and a patient and a family, and and you being informed and feeling comfortable with your treatment team. All of those things really matter, and you getting clear, concrete information is really the best way to go forward. And keeping your follow-ups is also important. So you don't want to be lost to follow-up with a cancer diagnosis. And most conditions typically require your standard management and primary treatment of the disease and surveillance, as you're sort of undergoing right now. You're still getting the hormone therapy, but the regular surveillance is typically up to about 5 years. So that established relationship you have with someone like your medical oncologist is going to be a long-term type of a relationship. So.
Awesome. Dr. Walker, can you please tell people where they could find you? And if they had other questions, can they reach out to you?
Yeah, sure. So I'm currently in Chicago, and Chicagoland, rather. I should clarify. Sorry about that. So I moved here to do hematology oncology training at University of Chicago, and I'm now working in the western suburbs at Elmhurst Memorial Hospital, which is part of the Edward Elmhurst Health System. You can find me at eehealth.org and just find a doctor, and I'm there. And, I think there are, I think there are links in terms of how to get in contact with us from that website. So,
Okay.
eehealth.org, and then you just, look up, it says find a doctor, and then you type in Dr. Walker. I think there's another person with the same last name who is a female person who does pediatrics, so definitely not me. And so I think you'll find me, if you go to the website. So, and,
Okay.
yeah.
Awesome. Thank you. And Ronald, thank you so much. And God bless you. And I know that
Thank
you,
you.
I mean, you sound like I said, you have an amazing team. So I know that you will be fine, and you'll be there for your family for many, many years to come.
Yeah.
Thank you so much.
Yeah, congratulations, Ron. Keep up the good work. It's been very nice talking with you. And yeah, I'm very impressed with, it seems like you are in very good hands and you are doing quite well. And I'm so pleased to hear that. Dr. Renee, thank you so much for inviting me to be a part of this discussion.
No problem. Everyone, thank you so much. And we'll see you next time in Black Doctor.